Good morning, ladies and gentlemen. It's an absolute privilege and a pleasure to be here and give the opening lecture at the 2017 BSCCP conference. As Teresa said, I work in the east of England and I have some experience using one of the adjunctive technology techniques which I will discuss with you today. Okay, so my disclosures. Guys, there seems to be a delay on the... Anybody? Okay, so DISIS. So DISIS is a adjunctive colposcopy system. So I think the most important thing for me to say first of all is you as the colposcopist are still in charge. It gives you additional information and it does not make the decisions for you. It is adjunctive and it gives you additional information. I would like to think it offers most significantly improvements for the women. Most importantly, I think we forget occasionally that there are women on the end of the cervixes that we look after. I think it gives significant improvements for you as colposcopists, and it also gives significant improvements for the services that we offer. You put acetic acid onto your cervix like normal, and then the aceto-whitening, one of the principal determinants which we're all very comfortable in terms of colposcopic practice, is then spectroscopically assessed. If I can get the thing to work. Sorry about this, guys. So you can see it spectroscopically adds your aceto-whitening, and then it turns your cervix into a colour-coded spectroscopic guided map, with blue suggestive of low-grade aceto-whitening, and the higher the intensity of the colour, suggesting that you may potentially have a higher amount of aceto or a denser amount of aceto-white staining, and it gives you this summative map, which is easily visible to both yourself and the patient. There's a significant emerging evidence base. I certainly don't expect you to read what is an incredibly busy slide in front of you. I'm here very much today as a clinician. Those of you who worked with me know that I'm certainly not an academic. Okay, so I give you today my opinion very much as a clinician, but there is a significant amount of emerging evidence base behind what we do. So it is actually today, I'm going to try and give you, if I can, a very personal view. And I suppose it starts off with why did I actually think, or why did I feel that I needed to get involved with adjunctive technology techniques? I suppose this goes back as far as 2012, 2013. I was at that point in time, I was one of the quality assurance directors for the east of England, and on the visits, obviously as part of my roles and responsibilities of that, I actually visit an awful lot of units, and very much off the record, I was being asked, do you have any experience of these technologies? Have you ever used them? Do you know what's going on? And I suddenly realised that it was potentially something I think I should probably begin to look at. So hopefully, although I'm a clinician, I'd like to think I'm evidence-based. So for me, the most important thing was actually, well, what's the evidence behind this? Does it actually say it does what it does on the tin? And I suppose I was actually drawn to DISIS initially because it is NICE recommended to be both clinically and cost-effective. I then wanted to actually go and actually see it being used, so I was lucky enough to go up to Gateshead, and my thanks to Raj and Anne, if they're somewhere in the audience, I actually got to see a live demonstration workshop in Gateshead, and it's something I very much, I suppose, copied myself in terms of it was really, really nice to see the technology in use in an average standard clinic. These patients weren't hand-picked. It wasn't a staged clinic, so you could actually see it, and my thanks to Raj and Anne for allowing me to do that and sort of pinching a little bit of their formula. I think like most people, I thought, well, this is probably only going to be useful for low-grade disease, but I think very, very quickly I found that actually I use it for high-grade management, I use it for potentially conservative management, for treatment, but also it has a significant other knock-on effects in terms of what it can provide to you and your department in terms of quality assurance, governance, education, and most importantly, what I'll finish with, actually what the patients think of it. Quite a lot of this conference is going to be speaking to you about some very significant changes in screening that's going to happen in the next few months and years. I'm certainly not going to go into too much detail to it, other than to say I'm sure you're well aware we've made the decision to begin to change to primary HPV screening, and the other main thing that's beginning to impact on us is the effect of vaccination. So we're beginning to see now significant numbers of young women who were vaccinated when they were in their early teens beginning to enter the cervical screening programme as they approach their 25th birthday in England. The results from the Sentinel sites would suggest that we are likely to see, in the short-term period, a significant increase in referrals to colposcopy, potentially 66%, before that actually begins to settle itself down as the vaccinated cohort becomes bigger. And because of actually taking away a significant proportion of HPV 16 and HPV 18, what I describe as the playground bullies of HPV, okay, you will actually potentially be changing the type of referrals that you see to colposcopy. So you will have a significant number of ladies referred to you with low-grade disease, and potentially also a significant number of women referred to you with a slightly different condition, which we haven't, those of us who don't work in the Sentinel sites haven't seen, which is those ladies who have a normal cytological exam but are persistently high-risk HPV positive. You will basically, in essence, potentially find it much harder to identify disease, and if you don't have the ability to confidently discharge your patients, either with or without biopsy, you will be potentially drowning in low-grade referrals, okay? So there is a significant fear. Those of us who were working when we went from HPV triage to test of cure will remember if you didn't follow the guidelines, if you didn't follow the policy, you had a very, very difficult times in terms of capacity. There's also been perhaps a suggestion that with this change in the percentage of HPV types that we're seeing, will we actually be seeing different colposcopies? And certainly, I think the evidence base in the field is certainly split. Some studies suggest that if you remove HPV in 16 and 18, colposcopically it looks different, but also there's an equal body of evidence that says actually the colposcopic appearances remain the same, irrespective of the type of high-risk HPV that's present. So what challenges do that, as it's going to evolve, then the challenges of what we're going to do is going to evolve. So as we've discussed already, capacity, I think, is actually going to be the really big one. Unless you actually have the ability to confidently discharge your patients or treat them at the right point in time, you're going to be drowning in low-grade disease. And potentially, the high-grade disease, which we're there to identify and potentially treat, is actually going to be much, much harder to find. I suppose my quality assurance background, though, says that actually I think we've still got then significant challenges in colposcopy. We are quite rightly proud of our cervical screening programme. We have what is still regarded as the world's best cervical screening programme, but when we get to the diagnostic arm of it, actually, how do you assure or how do you suggest the quality of something that is a qualitative procedure? Because a lot of the time you're not actually taking histology to grade it. So for me, those are, do you ever have the same view of the cervix? Do you ever have the same colposcopist? Do we use the same amount of acetic acid? Do we look at the cervix for as long as we should do? Because I'm pretty sure that some of us at some point in our career have just splashed on a little bit of acetic acid, left it for about 20 seconds, gave an opinion, and not really given the 2 to 3 minutes that we should do to be looking at the whole examination. Do we ever manage the same, do we ever manage patients the same? I'm not going to talk too much about the elephant in the room about low-grade biopsy, but it's quite clear that people manage low-grade disease and even high-grade disease very differently all around the country. And certainly most units I go to and visit, which is up to 22 every sort of 3-year cycle, still don't have what I would consider would be a credible image capture or archiving system to look at their colposcopies. So how does DISIS actually potentially change this? What does this adjunctive technology, how does it actually help us to address this? Well, first of all, and most importantly, for me, the exam for the first time ever in colposcopy is potentially reproducible, okay? You're getting the same view of the cervix because you're having to position it, the speculum's in the right place. You are effectively getting the same colposcopist. Because the whole examination is recorded, it's archived, I can look at the colposcopy 6 months previously, 12 months previously. It doesn't matter whether I did it, it doesn't matter whether my nurse colposcopist did it, it doesn't matter whether my colleague did it. So for the first time ever, you can actually realistically compare colposcopists against each other. Because it is an automated delivery system, you get the same amount of acetic acid, exactly the same amount of acetic acid every single examination. You look at it for the same amount of time. The map will not generate, it won't let you cheat and cut it short until you've actually looked at it for 2 minutes, so you get the same time. and you're beginning to look at the same parameters. We all put slightly different store on aceto whitening, abnormal vessel punctation. You're looking at aceto whitening as the same parameter and actually being quantitatively able to assess the aceto whitening. And perhaps most importantly, and I still come back to it, is the dynamic onboard documentation system. This is both static and video. Polaroid pictures are all very good, static images are all very good, but colposcopy is a dynamic examination. The aceto whitening, the colposcopic changes, they change throughout the 2 to 3 minutes. A picture, a Polaroid, is one point at a time in that. It doesn't really represent the whole colposcopic examination, but for the first time ever, that is actually recorded with the adjunctive technology on the top of it. So I thought I'd give you some examples just to show some nice things. So here's a discharge to normal, lady who's referred with low-grade disease, and you can see a very normal colposcopy, I would hope, and a very normal map, not suggesting any significant aceto whitening. I'm very happy to discharge her to 3 yearly follow-up. What about 12 months discharge? No biopsy. Low-grade referral. You see some dense aceto whitening, which then fades over time. Certainly, if you were to look at a static image at the start of that examination, you would think perhaps something different. A sea of blue, low-grade disease, potentially low-grade disease. I'm happy to not biopsy that lady. I think she's got a significant chance of regression. I'm happy to discharge her to the community for 12-month follow-up. Biopsy to confirm high-grade disease. So again, very, very different. Low-grade referral. And as you can see, very, very quickly and persistently, a very dense area of abnormal aceto white staining appears on the anterior lip of the cervix. You can then biopsy that, and that's confirmed as CIN3 on biopsy with that lady. So you've actually, in a low-grade referral, it's enabled you to find high-grade disease. So the thing that I'm then actually asked is, well, actually, does it change what you do? Are you then actually bullied by the computer that says, you need to do this, you need to do that? And certainly, I think that's one of the main advantages and strengths of DISIS is actually it doesn't bully you to do anything. You still have to make the decision as the colposcopist. So I come from a unit which has historically an extremely low biopsy rate. Again, with my quality assurance background, I felt I had to practice what I preached, and I felt that I had to be a great advocate for not biopsying when you didn't need to. So here we've got 24 months of local data. So JAB is myself, GF is my ex-nurse colposcopist who's sitting there. She's been seduced by another trust. I haven't quite forgiven her yet, but this is when she worked with me. You can see that actually these are low-grade referrals. So before DISIS, we had 289. Our biopsy rate was 8%. Yes, I'll just repeat that, 8%, okay? I know some of you biopsy up to 90%, but most importantly is our hit rate. What percentage of CIN are we picking up on those biopsies? So CIN and biopsy, 0.22. So for every 10 biopsies we take, we're identifying CIN in 2 of those biopsies, okay? 12 months after DISIS, though, you'll see 337 referrals, approximately the same. Biopsy rate 6%, so we're actually biopsying about the same number of patients, but actually hit rate 14%. So our hit rate has actually increased, and for every 10 biopsies we take now, we're actually identifying CIN in 7 patients. So it hasn't actually changed our practice because our biopsy rate remains identical, almost, but we've actually integrated it into our practice, and actually it's made me better. And you see it's made me significantly better. I've gone from 3 in 10 to 8 in 10. So admittedly they're small numbers, but I think, and what's very encouraging is this is replicated from the other units which are using DISIS regularly as well. It makes your biopsies more targeted. It doesn't actually change what you do, it just gives you better information and makes you more targeted when you do it. I've also been a great advocate for conservative management. Most of the presentations at Bradford last year talked about this in terms of had we potentially been over-treating a whole cohort of young women with CIN2 whose family might not be complete. So I think DISIS has given me another sort of armour to enable me to have a little bit more, I think, sort of comfort in managing these patients conservatively because I have a credible way of actually comparing what it is. So here's a case some of you might have seen from last year. There's a lady referred with severe dyskaryosis. She hasn't completed her family. She wishes to consider more children. and she has quite a large area of aceto-white, quite densely staining. The map suggested that of the areas of high-grade disease, these were biopsied, and they confirmed CIN2 on colposcopy. She was appropriately counselled. She took the decision to opt for conservative management. And then 6 months later, she has a repeat colposcopy and cytology, the same cervix, which suggested very low-grade disease. And then the beauty of a full archiving system is you can compare one against the other. So in a 6-month period, you see this young lady has been able to have a significant regression in her disease, and over the next 12 months, both her cytology and her colposcopy reverted to normal. She's been discharged to routine screening. She has retained the integrity of her cervix. Apart from the punch biopsies that was taken, no treatments have been undertaken to change the volume of her cervix. So for the first time ever, and it doesn't matter who saw her the first time, who saw her the second time, who saw her the third time, you've got the ability to actually credibly longitudinally track patients. In terms of disease and treatment, we spent a long time changing the ergonomics of the headpiece. The current machine is perfect for treatment, it's perfect for biopsy, it's easy to do. In essence, I don't think you need any other colposcope now. My particular areas of expertise, my background from a quality assurance point of view, it's reproducible. For the first time ever, it is reproducible. Every single exam is archived. There's a database in the, should you wish to use it. I know most people use Infoflex, South Coast, West Midlands, whatever you tend to do, but the full examination is archived. And it allows you to review it at the time. You can go back at the time of the colposcopy. You can go back to what it looked like at the start. You can go back to what it looked like halfway through. And you can actually then do distant and remote second opinions. So Gemma and I would often say, I saw this lady in clinic this morning, yesterday. This is what I've seen. Could you just have a look at the map? Are you happy with this? What do you think? Do you think I've done the right things? And as the world of telemedicine evolves, I'm sure you're aware, a lot of people are looking at the possibility of telemedicine in different parts of the medical profession. You know, there's nothing stopping me sitting in London and reviewing somebody's colposcopy in San Francisco or Sydney or Paris or Bedford or wherever it might be. So all of a sudden you're entering a digital age and the opportunity of both local and distant review. I think you can see that's got some significant medico-legal implications in terms of protection for yourself, in terms of what the cervix looked like, archived and actually recorded. And your MDT then becomes a completely different animal. So from a quality assurance point of view, we regard MDTs as one of the biggest barometers as to the credibility of your service, the safety of your service, as to the way in which it is set up and the parameters around it. You can actually now credibly review somebody's colposcopy. So we've been very lucky. We've been able to do that with cytology for years, with histology for years. You can look at the slides, you can look at the histology, but for the first time ever, you can actually critically appraise the colposcopy. You can record, you can watch the whole colposcopy. What did you do there? What did you do there? Did you biopsy in the right place? Did you not biopsy in the right place? It becomes a credible review. The educational possibilities for that are endless, and it's a very exciting world as it sort of moves into sort of digital education, the various platforms that are available. In terms of recording, I'm happy to name and shame myself, okay? I think you'll agree that this would be considered good documentation, okay? In a lot of places, the hard copy, compare that is the hard copy documentation compared to that is stored on my system. Okay. Not only do I have that map at the end, I have the entire examination that's gone before it, recorded. From a medico-legal point of view, it is worlds apart. In terms of practicalities, it took everybody in my time 2 clinics to familiarise themselves. It links with your PAS system very easily. It doesn't increase your time for each patient consultation, and it's suitable for both treatment and biopsy. And in terms of vulvoscopy, a number of people in the room will practice and will do vulvoscopies. It is very, very suitable for vulvoscopy when we're trying to be credible in terms of conservative management, not unnecessarily removing parts of ladies' external genitalia. You can educate patients, show them where to use topical treatment in terms of steroids, imiquimod, biopsies, etc. Patient satisfaction was the really unexpected one for me. I've been looking after a lady for years and years and years with high-grade CGIN in the days when we did it every 6 months. I showed her the map and she said, "Thank God for that. For the first time, Mr. Brady, I actually understand what you're talking about," which I felt was a little bit embarrassing, but actually they understood the map. The patients were extremely happy, and Gemma went on to do a multi-centre patient satisfaction survey that was actually presented at the World Congress in 2015. My hope is that if we can reduce the anxiety amongst patients, we can hopefully potentially reduce the DNA rate. The DNA rate amongst our patients is high in terms of follow-up. Hopefully, this will be a knock-on effect to be the two. And my final slide, you'll be delighted to know, is actually why I think we do it and why I think we have to improve. And I think doctors are a slightly tricky group of individuals because we all think we're absolutely brilliant, okay? And actually most of the time we're not, and I think we can actually improve significantly. So I think we're obligated to look at things to try and improve things for our patients, and the world of cervical screening is changing very, very rapidly. So in the bottom right-hand corner are the two women in my life. The slightly older one holding the cocktail, okay, is my wife, who, without giving too much away, is just about to go from 3 yearly screening to 5 yearly screening, okay, all right? She has been very, very well served by the cervical screening system. Should she have ever needed a colposcopy, I'm pretty sure she would have been well looked after, and I have every faith in that. The slightly younger girl on the right, reassuringly without the cocktail in her hand, okay, is my daughter. Now, she's 13 years old, she's just received her doses of Gardasil, she's been vaccinated, so she now enters a different point in the cervical screening programme. And when she's invited for screening, I hope that she would have a much better opportunity with the technology that is afforded. Ladies and gentlemen, thank you, and sorry for going over time.